Thank you for joining our first state technical assistance webinar of 2024. And we're really happy to have you all joining us today as we're thinking about working towards a health equity and anti-racist approach to child safety. This is a topic that's really near and dear to our hearts at CSN. We've been working on health equity for a number of years. And we're really happy to have a fantastic panel of presenters today to help you think through this for your context. So the Children's Safety Network is funded by the Health Resources and Services Administration at the Department of Health and Human Services. And we are HRSA's primary vehicle for technical assistance for child safety in the US. So nothing that we share should be misconstrued as the opinion of the government. We have three extraordinary presenters today that I've had the privilege of working with in different contexts. First, we will have Rebecca Bishop, who's been a member of the Equity, Diversity, and Inclusion Committee with me in our organization at Education Development Center. She's a public health professional with over 14 years of experience directing large-scale prevention and intervention programs focused on building health equity. She has experience leading a hospital-based violence prevention program, managing substance misuse prevention services for an urban municipality, and directing the first technical assistance center in the US focused on problem gambling prevention, where she pioneered a training academy that focused on problem gambling prevention science, and equitable practices. She's an expert in developing and implementing evidence-based interventions and programming, providing high-quality training and technical assistance, and leading community-based initiatives aimed at promoting health equity. She's an experienced public speaker and facilitator. She's skilled in managing cross-functional teams, communicating among cultures, and making critical decisions during challenges. She received her BA from Post University and her MSW, Master of Social Work, from Boston College. So welcome, Rebecca. And next we will have Dr. Sadiqa Kendi, who's a pediatric emergency medicine physician and associate professor of pediatrics at Boston Medical Center and the Boston University Chobanian and Avedisian School of Medicine. Dr. Kendi is an injury prevention researcher with a focus on equity. She graduated AOA in 2006 from the Yale School of Medicine. She received her pediatrics training from the social pediatrics program at the Children's Hospital at Montefiore, where she spent an additional year as a pediatric chief resident. She completed her fellowship training in pediatric emergency medicine at the Children's Hospital of Philadelphia and her MPH training at Bloomberg American Health as a Bloomberg American Health Initiative Fellow at the Johns Hopkins University Bloomberg School of Public Health. And Dawne Gardner holds the position of Senior Manager of Equity and Child Safety at Safe Kids Worldwide. And in this role, she's responsible for managing the execution of the organization's comprehensive equity and child safety strategy. Additionally, she provides guidance for the growth and advancement of Safe Kids' strategic framework to reach communities that have been historically marginalized and underserved. She also oversees the Safe Kids Equity Advisory Committee. And prior to joining Safe Kids Worldwide, she works for over 15 years in injury prevention at Cincinnati Children's Hospital in Ohio. So some folks from Ohio are on the call today. During this time, she focused on the development and implementation of prevention programs in underserved and marginalized communities. Her focused work played a significant role in eliminating disparities and addressing barriers to childhood injury prevention. As a result, there have been measurable decreases in the frequency of pediatric unintentional injuries treated at local emergency rooms in the area. And Dawne Gardner is also part of the Safe Kids and Health Equity and Anti-Racism work group that I'm also a member of. So we're very happy to have you all with us today and sharing your expertise on this topic and moving our work forward. So I will hand it over to Rebecca Bishop.
Thank you, Maria. Bear with me here while I share my presentation. All right, can you see my presentation now?
Yes, we can.
All right, perfect. So I am just the starter today. I'm just going to ground you guys in these concepts and definitions. As Maria talked about, you guys apparently have been doing this for a while. So even if you are familiar with this, I encourage you to think about these concepts differently, or think about how you would present it to someone else. This first part of this is thinking about health equity and an anti-racist approach as definitions, right? I think sometimes when we know about this work and we're in this work, we have a lot of jargon. And when people are trying to learn this work, it's often difficult to understand, what do we really mean by these words? And then the second thing is I want to provide some tips to when implementing a health equity anti-racist approach to think about. And I use the framework for this project, First 10, to kind of put these into some buckets that we'll take a look at. Okay. Do we have a poll here, Maria? Perfect. Poll popped up. Are you familiar with health equity and an anti-racist approach? Of course you are. Maybe. As the results are coming in, I'm going to give folks a few more minutes. We've almost all participated. Okay. It's looking like about 70% of folks do know. It looks like it's going up a bit. 71% of folks are familiar with this. About 5% are not, so we're hoping you learned something new. And a few folks feel like this sounds familiar. Perfect. There you go, results, right? So there's some work to be done. Let's take a look at this. Bear with me. All right. Let's first take a look at what health equity is. I know at this point we all have heard a definition of health equity, right? It is a buzzword. We know that a big part of health equity is about everyone having a fair and just opportunity to be healthy. One thing we don't always acknowledge or talk about is that health equity includes addressing historical and contemporary injustices and the elimination of disparities. I think that feels really big sometimes. And the other big piece about health equity is addressing social determinants of health, right? They are the social, economic, and environmental conditions that we all live in, work in, and play in, right? I often use this image to help people who don't get it or don't get the concepts of, well, what do you mean? What could this look like, right? This illustration of jumping over barriers, having to, right? So many people know what health equity is. The other thing I wanted to pull out about health equity is, in order to achieve this health equity, right? It's really important to improve access to conditions and resources that strongly influence health. And if you think about with social determinants, what we're trying to do, it is, right, give people access to things like good jobs and fair pay. If you think about this initiative, this is about high quality education, right? Providing access to that, safe housing, healthy physical and social supports, and there's others, right, including healthcare, access to healthcare, and a number of other things. But I think when we talk about achieving health equity, we don't always name how we're going to change the conditions and the resources that strongly influence health. But I would argue in this approach, you have to specifically target conditions and the resources piece. But we'll talk more about that. There's high quality healthcare. When we think about anti-racist, and feel free to write it in the chats. Anyone have a definition for what anti-racist means? What do you use? Any thoughts? All right, let's jump right in. You know, when I talk about this, I often talk about anti-racist being a verb, right? And we don't think about it when we think about anti-racist is often a name or something people, I think, refer to as it's almost a name you call someone, right? But anti-racist is intended to be a verb, and it's the active process of identifying or eliminating racism. Um, and I think if you think about it in that way, you have to do something when you think about being anti-racist. And we know that this specifically focuses on changing systems, changing organizational structures, policies, and practices. And the purpose specifically of being anti-racist is to redistribute power, right? I think in some environments that's incredibly controversial. But when we talk about equity, when we talk about being anti-racist, it's almost necessary if we're going to make space for other people. The other conditions or things to think about, we know anti-racist uniquely names racism and its impact to individuals and communities. There are many projects that are focused on health equity that never say the word racism, right? And this is where being anti-racist is different, right? Structural racism is a fundamental driver of health disparities. Again, you know, this may be a sentence in some health equity work, but it's often not a focus. And I think you're going to hear for some projects today that have really distilled down this structure, what it means to address structural racism, right, as a fundamental driver for disparities. And then finally, and being anti-racist focuses on dismantling racism in all aspects of society. And I guess the one I would point out is also within, not just within organizations, but I would talk about within ourselves, and I would talk about amongst people, right? We'll talk more about this when we talk about different environments that young people thrive in. But if any of us are going to do this work, right, and say we're trying to build anything to be anti-racist, it's important that we do some internal work, right? So that's the other thing I would include in terms of being what anti-racist means. So we just talked about those two definitions, right? When you think about what they have in common, right, rather than what's different, here are some things I just picked out, right? This idea of addressing systemic inequalities, right? This idea of naming racism as a driver of those. The emphasis on social determinants. How are you providing that access to social determinants, right? Or how are you improving conditions that people live, work, and play in? Promoting cultural competence and representation. This can mean a lot of things in different cultures, right? Or in different contexts, but it's incredibly important that culture is a part of of whatever health equity and anti-racist approaches occur. I think in some environments, especially in some education environments, I think there are still schools today that don't talk about culture or don't think it's important, or the only culture that's important is American culture. The final two things are around research and data collection. We know we can't identify disparities if data is not a part of the issue. If you're not collecting data on ethnic and racial groups, it's an essential component to know where to target and what interventions will work. Finally, community engagement and empowerment. It's an essential part. If you're not including the people who, particularly marginalized communities, right, in your area, if you're not including them in efforts, right, how can you reach them? thoughts about this? Those of you who said you've never heard of this, thoughts and reactions to this? Those of you who said it sounds familiar, can you guys write in the chat some reactions to this? Feel free to unmute, or if you raise your hand. Maria, how does it work?
Anyone can unmute at any time. So
Okay.
if anyone
Perfect.
wants to share anything, they can go ahead. I'm curious specifically on how folks, especially the folks who are coming in from state health departments, how they're already integrating components of this approach that you're listing for us here. How
Mhm.
they may be doing 2 or 3 or 4 of these things, or maybe they're doing one of them and they need to increase it. So I would love to hear a bit more. Jeannie Beats actually has just shared. Jeannie, would you like to unmute and speak?
That was going to happen. I guess I am somewhat familiar with this, and so that was my answer. And so that I had not heard kind of anti-racist in a verb. I always thought it was like particular person and what they did, and not looking at. I mean, I knew it's kind of looking at the systematic structure, but it's more coming from a person, individual, not a verb, action.
Mhm. Absolutely. And when you think about that, it's almost it I think it implores you to think about what action are you doing, right? Um, the other thing I think, to Maria, your question, I'm going to get into some tips, some concrete ways to do this, right? But I think if you're getting TA from this group, right? If you're involved in health equity work, you're doing some of this work, right? Um, uh, uh, it's often in our fields where language changes and it makes you seem like, oh, is this a completely new thing, right? It's actually not, right? In health equity, you were focusing on social determinants of health. In health equity, you are identifying disparities with data, right, to intervene, right? In health equity, you are focusing on marginalized populations, right, and trying to find ways to engage them. This gives you something, in some ways, spells things out, right, like cultural competence and representation. The other thing that this does, and there, I think the conversation here is about implementation, but it specifically names race, right? And environments have to be ready for that, right? And so that may be the added challenge if folks are not already doing this work. But if you're doing equity work, you've had to identify some disparities. So that's where I would start. Thinking about the verb, to your point, Jenny, that you brought up. I'm wondering, Maria, if it makes sense, let's move into some tips, because I think that can help make things a bit more concrete for folks. I organize these tips into kind of 3 sections. When we think about creating caring, equitable community of engaged learners, right? How can we do that using this approach? Same for teacher training and professional development. What are some specific concrete things people can do, right, if we're going to follow this approach? And then the same with partnership and engagement. The first thing that I'm going to suggest is to foster an engagement where children feel valued, respected, and included. Now, that probably sounds like a duh, but we know that if we think about schools, not all schools are welcoming, right? Not all schools, the experience that kids feel when they walk through the doors is not they don't feel respected. They don't feel valued, right? We know that, you know, academics is often put in front of child needs, right? Which is why we have initiatives like this. We know that when kids get into, community programs, they're starving because they haven't eaten. Actually, I heard someone talking about their kid being starving when they get out of school. Mine is too, right? But I think there are some ways to be more concrete about how you do this. You know, one of the things that I love to see is teachers who have a separate handshake for each student. As small as that is, what that does do is give some individual attention to that student, right, in a way that that student wants. Implement some kind of cultural education. I strongly recommend this. There's lots of ways to do this. It's a way to celebrate diversity, different cultures and identities in the classroom, to normalize it. We know that kids are prepared to talk about, or at least they notice race differences, right? As young as before they get into kindergarten, right? Talking about it can help give them language, right? And if it's inclusive language, that's a real start, right? And it would be different from how the environments that certainly we grew up in. Encourage curiosity with young people. You know, when we get into trainings that talk about race, we do lots of grounding activities to help everyone feel comfortable. What does that look like in young people? There's a number of books and teaching resources to help educators talk to young people about whether it's race, whether it's other topics that happen in popular culture that kids are paying attention to. Talk about history. Talk about not just talk about racial justice events, civil rights events. If we think about what's happening now in the world, my son is 8 and he's asked me about it already, right? The things that are happening around us, kids see and hear. Think about your physical classroom, right? Or physical classroom. So you think about play areas, right? In any environment. Are there welcoming messages? Free from racial stereotypes? What kind of diverse messaging are you sending? Posters, what kinds of books are included in the curriculum? These are things that get embedded in classroom activities, right? How do we make that part of the culture? The other thing is, if we think about the emotional state of kids, how do you create environments where kids feel safe to express their identities and their experiences without full judgment? How do you really create that culture for kids? Are there any others? Maybe there are things you're doing, things you've heard. What else any concrete things that people can think of, or perhaps you're already doing to encourage equitable communities among the young learners with young people? Could be a small thing. It could be just a quick strategy.
Yeah, Rebecca, we've had a couple of comments in the chat. Alexander from the Illinois Department of Public Health said that in Illinois, all of the grants require grantees to address social determinants of health and to think about how to integrate them into each aspect of the program. Marissa also shared that they're trying to address better data collection at their child fatality death review, but it's hard to know what meaningful categories to collect aside from race, ethnicity, and income. They oftentimes don't have access to other sources of data. Jessica in New Jersey said that our grants have to have youth advisory boards, so they're bringing in youth voice into their grants. And Kelsey in Rhode Island said that at the Department of Health, they have health equity as one of their 3 leading priorities. So they really try to integrate these components into all of the work that they do.
Nice, nice.
Yeah,
great.
And I really appreciate, Rebecca, at least from the suicide and self-harm perspective, prevention perspective, I really appreciate you talking about communities of learners, because much of the programming happens at the school. And it's something that that state health departments often struggle with, of how to integrate this language into a school environment. So I appreciate your discussion of learners and communities of learners.
No, absolutely. And then that comment about data, one of the things that is certainly an uphill battle, but think about if your current data is not working for you, I would begin to think about a rationale to advocate to collect different data. Because, and I would encourage you to continue to look at the social determinants of health. There's even some cities and towns who have had to collaborate with, let's say, homeless services to get a count on not just who has a home, but who doesn't have a home, right? And to try to think creatively about what specific data to collect. But it's great work. Thank you so much. Great work. I have two more here. I just want to continue to give some concrete strategies. The next one is also thinking about classroom, schools, where kids are, teacher training and development, thinking about education teachers need. Sometimes this is implicit bias training, but there's lots of other types of equity, anti-racist focused trainings that teachers can have. I talked about the importance of that internal piece, doing your own work on this topic as a teacher so that you can present this content. It's not easy to just pick it up and run, especially if you're not used to having conversations like this. Think about how to create inclusive classrooms. These are the things that help adults feel comfortable, and it will help kids feel comfortable as well. Involving children, families, and educators in decision-making. You know, I would say the research is out on this, that when you make people feel involved, when you include them, right? And then finally, review policies, practices, using a health equity and anti-racist lens. And I think when you do that, you'll start to question, wait a minute, how can we do that? That's not fair to everyone. How can we support certain groups more? Here's that individual piece again around challenging racism. And people are watching you. If you are a leader that's implementing this work, people are going to be looking to you and looking to your actions. Finally, just for the sake of time, this final piece is partnership and engagement. Really, really, really important in this space. Partnership and engagement is the cornerstone of one, engaging marginalized communities, whether that's families at schools, whether that's any equity-focused initiative really needs that. Families we know are important to collaborate, to partnership with. It's important to understand their unique needs, right? That's that component of health equity. And then understanding their cultural backgrounds. It does make more work for us, but it makes for a better partnership. Also, there's that involving families in decision-making. You know, and the importance of understanding cultural norms and values and communication styles connected to planning particularly. And then finally, community organizations are the lifeline, right? They will provide those social determinants when the environment can't. Maria, for the sake of time, we're not going to do this just for the sake of time, folks, but as we said, a lot of you guys are probably starting to do some of this stuff. And if not, hopefully this has begun to pique your interest to say, huh, I'm curious about this. Maria?
Great. Thank you so much, Rebecca. I will suggest that we keep questions till the end. So if you have any questions specifically for Rebecca, please go ahead and put them in the chat and we'll get to them after the next presentation. Thank you so much, Rebecca. This was really helpful to help frame our discussion and to think about communities of learners and how we can integrate health equity from the State Health Department perspective. So great. If you could stop sharing, then we will go on to Dawne and Dr. Kendi's presentation. Thank you so much.
All right, everyone. Are you all able to see my slides? Yes, okay.
Yes, we are.
Excellent. Let me just get my screen set up here. All right. Well, thank you so much, Rebecca, for your talk. I think grounding us in the concepts of health equity and anti-racism was really helpful for our discussion, because we'll be talking about equity specifically in child safety and injury prevention. And I think a lot of what we're talking about will build on some of the really kind of base and foundational concepts that Rebecca talked about. So we all know there are significant inequities in injury outcomes based on race and ethnicity, based on geographic location, and socioeconomic status. They were summarized by the Children's Safety Network. This was a white paper published back in 2017. There have been many other publications that have talked about it.
Dr. Kendi, I'm sorry, your screen is not sharing properly.
Oh,
It looks
really?
like
Let me
it's frozen, actually.
Huh. Okay, let me stop sharing and try again. I'm not sure why it's doing that. You're still able to hear me okay?
Yes, we can hear you okay, and we can see you okay. It was just the sharing, but we do appreciate the shout out for our white paper.
Let me try one more time. Let's see.
Okay,
Okay.
that's perfect.
You're seeing it now. All right, but hopefully it works this time. We'll see how it goes. Please jump in and let me know if it stops working again. All right, so I was just saying, you know, there are a lot of publications that talk about injury inequities, and so we know about those, and Dawne will discuss them a little bit later in the presentation. So I'm not going to spend much time on that now, but I do want to talk a little bit about a conceptual framework that I developed with colleagues to think systematically about injury inequities, which is called the Injury Equity Framework. I'm going to review the framework and walk through an example utilizing the framework, and then Dawne will share how our work at Safe Kids Worldwide and equity and child safety is based on the injury equity framework as its conceptual foundation. All right, Maria, will you give me a thumbs up if you can see the next slide?
It's whenever you switch slides. So if it's okay, I will go ahead and share my screen.
Sure. Yeah,
and you can just let me know when you'd like me to change to move
sure.
slide. Sorry about that.
Yes, I'm sorry that that's happening.
All right.
Okay, great. And let me just minimize this. Okay. Great. So, so as I was saying, I'm just going to give an example as I talk about the injury equity framework. This is the full framework here. It was developed using the Cliff of Good Health, which was published by Dr. Kamara Phyllis Jones, which she has an article that was published many years ago on this. If you have not read it, I think it's really a really helpful read, whether you're thinking about injury, other types of health outcomes. I think it's a really helpful read. The framework is also based on the Haddon Matrix, which was utilized in public health to evaluate factors impacting outcomes. It has been used for COVID-19, has been used for injury, and then also based on the socio-ecological framework and the concept of intersectionality. So we'll use an example to walk through the framework, and I'll explain each section. I know that was a mouthful of different things that I mentioned that is based on, but we'll talk through each of those. Okay, you can go forward. So the example that I'm going to use is a tragic case that occurred not far from the Safe Kids Worldwide office in Prince George's County. In this case, two children were struck and killed while walking to school. Sky, who was 5 years old, and Shalom, who was a 10-year-old twin, and whose family had immigrated from Cameroon about 5 months prior. They attended Riverdale Elementary School, a school which has 96% of its enrollment for minoritized groups, and almost 100% of students walk to school. So I'm using this case to highlight a known disparity in pedestrian injuries. The rate of death of African American and American Indian pedestrians under 19 years of age is 1.8 times that of white children, and a little under 3 times that of Asian and Pacific Islander children. So let's walk through the framework using this case within the context of that inequity. So you can go to the next slide. So it's important to start within the societal context. And when we're thinking about inequities, the societal context includes multiple forms of bigotry. And this is part of what Rebecca was getting at. Racism is one form that we need to think about, and we have to think about both the historical factors because they really help to inform what's happening currently. The other types of bigotry that we need to consider include ableism, classism, homophobia, sexism, transphobia, and xenophobia. We can go to the next slide. Next, we consider intersectionality, which is the interconnectedness of various identities of a group or individual. So this is where the socio-ecological framework is included, as outcomes are impacted by the individual, family, and community factors. So as we think about this case, let's think about intersectionality in the context of community and family factors. So we had 2 children of color, one of whom was a recent immigrant from Cameroon. They went to a school in which 95% of children qualify for free or reduced lunch, which speaks to the socioeconomic status of many children at the school. It was an urban community. And I would argue that there was a history of disinvestment in the community, given that there was a lack of a crossing guard, despite the school being almost 100% walkers. You can go to the next slide. So then we add in elements of the Hatter matrix. So that's the pre-event, event, and post-event phases. So the pre-event phase refers to what was in place before the crash occurred that may have contributed to it happening or prevented it from happening. So for example, in this case, there were crosswalks, which we know can help to prevent pedestrian injuries. The event phase refers to factors that impact the actual crash. So an example of this would be the type of car that was being driven, which impacted the way the crash occurred and the severity of injuries, which we'll talk about more later. And then the post-event phase refers to what happened after the crash. For example, the EMS response, time to a trauma center, and the post-acute care. You can go to the next slide. So now we add in the contributors and countermeasures, which include the built and natural environment, as you see in the purple here, legislation and policy, education, equipment and technology, and treatment and recovery. I think of each of these as a different layer of protection. So the more layers of protection that are acting as countermeasures, preventing injury, the better. The more layers of protection that are deficient, acting as contributors, then the higher risk of the occurrence of an injury and increased injury severity. The issue with inequities, as described by Kamara Phyllis Jones's cliff analogy, is that there are certain groups that start at higher risk of whatever outcome. In this case, we're talking about injuries, because of the impact of the forms of bigotry at the top of the framework, which impact their social determinants of health. Then when you think about the ways the layers of contributors each contribute to inequities, you can understand how they compound to cause the substantial inequities we have in current society. The impact of these layers and whether they're acting as contributors or countermeasures then impacts the injury outcome, and even whether the result is a fatal injury, severe or moderate injury, or whether the injury is prevented completely. So let's talk about contributors in pedestrian injuries specifically, many of which were likely important in the tragic case outside of Riverdale Elementary School. You can go to the next the next slide. So if we go back to this case, let's just start with, we'll just think about the different components within the purple. So the first one was the built environment. And this is actually, on this slide, you can see a picture of the intersection where the crash happened. I'm not sure if you saw, in the first picture was an aerial picture, and you could see that there was a 4-way stop with the crosswalk. And so I would say that's a countermeasure, or something that could reduce the likelihood of injury. The next purple is legislation and policy, and the next kind of group of contributors and countermeasures. For legislation and policy, I think the thing that likely impacted in this case was enforcement. And so when we think about enforcement, there was a history of rolling stops at the 4-way stop. And so even though there was a 4-way stop sign with that history of rolling stops, there hadn't been an enforcement of actually stopping at the stop sign. There had been no crossing guard replacement after retirement of the previous crossing guard. And this is in a school, again, with almost 100% of the children walking to school. There is evidence that crossing guards can reduce the prevalence of pedestrian injuries. We know that. And so the fact that the crossing guard was not replaced, I think, is something that has to be discussed, and that's a policy issue. This was a problem systematically, and we know that it was worsened during the COVID pandemic, the kind of limitation in crossing guards. But I would suspect that this is an inequity in this community specifically, especially given so many kids walk in the community. If we think about the next category, equipment and technology, the van pictured here is actually the van that was involved in the crash. And so it's a larger kind of older model van with a high grille and no pedestrian detection. And so that's a contributor to this, likely to this. We know pedestrian detection exists in newer and often more expensive cars. And the fact that this van had a high grille is very dangerous for kids, given that their heads are lowered to the ground and likely increase the injury severity. For education, we know that children, especially children under 10, are unlikely to be able to walk independently. Obviously, that depends on different children, but that's one significant challenge. And in this case, one of the children, actually the older child, was the one who had pretty recently immigrated from another country. And so that child may not have been used to the traffic patterns at the intersections, and so would be at more risk, for example, than a child who was used to the traffic patterns. And then the next category is treatment and recovery. So there's not a lot of data on this case specifically, but I think it's just important to mention that the literature on increased mortality rates exists, showing that there's increased mortality in Black pediatric trauma patients in comparison to trauma patients of other races. Decreased response of healthcare providers to pain, which I think is really important to me as a healthcare provider, decreased access to rehabilitation services, and even increased response time by EMS to certain neighborhoods. So all of those are potential contributors. So this is just one example to help us think about inequities in pedestrian outcomes. I think if we stop and think about the whole picture, which includes the various layers of contributors and countermeasures and the complexity of how they come together to create these significant inequities, it's really important for us to do multidisciplinary work, which I think is one of the things that Rebecca mentioned in her presentation. That multidisciplinary work is what's needed to be able to address these inequities and move the needle. So I'm really honored to work with Safe Kids Worldwide on this work. I act as chair of the Equity Advisory Committee, and we provide input from an academic lens to support implementation of the strategic plan focused on equity and child safety. This is a list of the members of the EAC, which includes members from various academic institutions, as well as the American Academy of Pediatrics and the National Center for Fatality Review and Prevention. I will now turn it over to Dawne to discuss more.
Thank you. Thank you, Dr. Kendi. Next slide, please. Safe Kids Worldwide's 3-year strategic plan is a product of reevaluating and redirecting the Safe Kids Worldwide approach to pediatric injury prevention, with the injury equity framework serving as a conceptual foundation. The mission of Safe Kids Worldwide remains focused on reducing unintentional injuries among children ages 0 to 14, with a renewed emphasis on identifying and engaging marginalized and underserved communities and establishing equitable and sustainable systems of injury prevention. Next slide, please. As illustrated in this slide, disparities in unintentional injury death rates among children ages 0 to 14 are profoundly influenced by inequities related to race and geographic location, and these inequities are further exacerbated by poverty. Safe Kids Worldwide's mission is to ensure equitable access and benefits of injury prevention strategies for all children. So as we established our strategic priorities, we took into account the factors that affect the safety of marginalized groups. Additionally, we considered the complex interplay between the various forms of marginalization and multiple injury mechanisms when prioritizing our efforts to examine the historical and current patterns that have created the inequities we see today. Next slide, please. Safe Kids Worldwide framework prioritizes equity and impact by gathering evidence and practice to help validate interventions to scale, designing evidence-based education and awareness interventions, and advocating for laws and policies, all creating a proactive and multidimensional approach from a local, state, and national level to support a sustainable system of change. In implementing this holistic approach, we consider the contributors and countermeasures and acknowledge the role played by racism, ableism, sexism, classism, homophobia, transphobia, which Dr. Kendi mentioned earlier, are all contributing factors to inequitable injury outcomes. Next slide, please. Some of the concrete work within the strategic plan supporting representation, accessibility, and empowerment include, as Dr. Kendi mentioned, the Safe Kids Worldwide's Equity Advisory Committee that consists of the academia experts who provide guidance for implementing the strategic plan and collaborate on applied research in our strategically focused areas of injury prevention, namely child passenger safety, safe sleep, and water safety. And we are so grateful to have Dr. Kendi as the Equity Advisory Committee Chair. Our Evolving Strategic Collaborate Group, which aims to involve government agencies, national cross-injury organizations, and equitable partners in supporting the implementation of the strategic plan, and the Safe Kids Worldwide Child Safety Index. Next slide, please. Safe Kids Worldwide's Child Safety Index serves as a tangible tool helping to prioritize efforts in identifying marginalized and underserved and under-resourced communities. The CSI aids in identifying communities that are at a higher rate of risk for injury by utilizing index scores that assign weights based on community characteristics linked to risks. Next slide, please. So we know finding solutions to reducing unintentional injuries to children is often a complex and challenging task. Safe Kids Worldwide is dedicated to promoting the implementation of sustainable and equitable injury prevention models, particularly in marginalized and underserved communities, because all children benefit when we make equity a priority. Thank you.
Great, thank you so much. This was a really wonderful presentation and gave us a lot of food for thought. So I would love to open it up to our audience to see what questions they have, what questions, considerations, food for thought, things that they would like additional information about as they're working through this. So I saw some comments had come in, some additional questions about social determinants of health. I know that Sim had chatted. I see a couple of our CSLC members are here. So please go ahead and ask your questions. How are you going to try to integrate an health equity and anti-racist approach in your work? What components are you doing, or what components are you doing well? What components do you need additional help with? And maybe we can get some more suggestions and recommendations from our other attendees. Terry?
First of all, thanks for that presentation and the analysis of the crash itself and the with the health equity lens. I think oftentimes our law enforcement and or even highway safety folks who are looking at these crashes may or may not be looking at it through that lens. And so a resource for me would be, a guide for that process that I could share with them, or maybe some type of educational material for law enforcement as they work these accidents. I will say pedestrian deaths have become a huge problem for Nashville for sure. We're in Tennessee and other areas in Tennessee, and serve on the pedestrian task force. And I think this would be very helpful. Those kind of resources from you guys would be helpful to share with them. And I don't know that meeting, the pedestrian task force, is a hybrid meeting. Right now, they've tried to move back to in person. Some agencies are hybrid, some are full. But if there is a chance for that hybrid or a online meeting, I would love to have one of you guys come and share that work, or just that perspective, right? What hit me pretty hard was oh, they didn't replace their crossing guard. Something as simple as that, you know, it has to do with lack of resources for that particular district, or a decision to put the resources somewhere else. Yeah, that was a very enlightening thing. And I apologize for my Clark Kent glasses. This is not usual for me, but my contacts are killing me with all this cold weather and the heat running constantly. So, but thanks for the presentation.
Thank you so much for that comment. I'll just say, like, we're happy to speak to anyone. And if you know, I will make sure that my email is in the chat. You know, feel free to reach out. We're happy to speak and, you know, provide this this talk or any other to any group. And we're actually working on kind of a working tool that goes along with the framework to be able to assist for, you know, anyone in any field, because I really think that the last piece of, you know, what I mentioned in terms of this being multidisciplinary work, I think that that is true. And so having people who are you know, out there analyzing a crash, like helping them with that equity lens, is something that we're really happy to do.
Yeah, I don't want to leave the impression they're not aware of it all, but you know, I think one of our big problem areas that have been identified in Nashville is people crossing 5 lanes of traffic to get to work. Right, there are no walkways over the 5 lanes of road, or to get to a bus station. So bus stations are not on the right side of the road, and so these are all things that they are poor design. There are design elements that are poor, but they're designed poorly, I think, because people didn't think of those. They didn't design it with a health equity lens, right? That many of these people need to walk to work or walk to the bus station and get to those. And I probably hearing some of that in other states. I'd be interested to hear what other states are doing and how they're when they work with our highway safety office, if these issues are coming up. I mean, they have identified spots, but unfortunately, they're identifying them after the fact rather than designing in a way. Well, in the past, did not design. Perhaps in the future. Anyway, I'll sign off and let others speak.
Terry, you're speaking to my heart. I live across the street from my son's elementary school, and it is a no-walk school. He has to get on the school bus to go to school because they don't have a light or a crossing guard or a stop sign, despite it being literally just one intersection. So from an equity perspective of having people not have vehicles or not be able to wait for the bus, folks that need to get to work on time, not being able to walk across the street and wait for a school bus instead is very different. Great. Any other comments or questions, considerations? Thank you, Dr. Kendi, for putting your email address in the chat. We really appreciate that. I know we have a couple of other folks that have grappled with health equity. I see Chris in California. I'm going to call you out, Chris, has been trying to integrate different community voices in the suicide prevention work in California. So he's been doing a great job of that. I don't know, Chris, if you have any other questions or comments or reflections based on the presentations today.
No, I don't. I think for us, you know, just really doing a deep dive into our minority groups, specifically we have a Black infant health program in our agency. Utilizing them, we also have an Indigenous health program that we work with. And since I'm part of this cohort this year, I think we're probably going to do even more work with those individuals to try and really reinforce the health equity piece. So thank you to all the presenters today.
Great, thanks, Chris. And I see Taurine, am I saying your name correctly?
You are, thank you.
Yeah.
I just wanted to highlight to Terry's point, I have been presenting to the state highway safety offices through the Governor Highway Safety Association and really trying to align the work that we're doing through equity, but also with an emphasis on our child safety index. that's really leading us through the zip code tabulation of the work that we did with over 40,000 zip codes. So now we're looking at schools and where those schools are in the very high-risk communities. And so you'll see more information aligning with Dawne's presentation today that will show you where we know we have to do more education and awareness, especially around pedestrians, and thinking through the electric vehicles that are coming to market now, how quiet they are, how heavy they are, and the risk to pedestrians. So more to come on that. I would just say that stay tuned to our website, and also too at Lifesavers, we'll be talking quite a bit about that in Colorado, I'm sorry.
Great, thank you so much. And we do encourage you, if you have any resources or anything that you'd like to share, we can always send them out or post them on our site as a follow-up. So if you have anything that you'd like to share, we're more than happy to share it out. Great. So we do have a few minutes left. If you do have any additional questions or comments, please feel free to put them in the chat and we will try to address them. I just wanted to close out with a couple of items from CSN. One is thank you, Claire Grace. She has posted our evaluation feedback for today. We preach continuous quality improvement, but we try to live it as well. So we do take into consideration your feedback as much as we can in creating these events and in thinking through different topics that would be of use for our states. I also have a couple of resources that we have at CSN that are available on our website. So as you're thinking about how you're working through health equity in your states, you can go ahead and access our resources on our website. We have two tools available. One is our health equity planner to implement and spread child safety strategies in communities. And it's a really great tool for you to start thinking about health equity in your departments or in your programmatic, depending on the level that you're working in. So please feel free to go ahead and check that out. It is an editable PDF, so you can work on it and take notes. And then the other tool that we have that we worked on with the National Center for Fatality Review Prevention, our Children's Safety Now Alliance, and Safe Kids Worldwide is the Health Equity, Diversity, Equity, and Inclusion Assessment Guide for Multidisciplinary Teams. So trying to get to what we've been talking about in today in multidisciplinary teams and working across agencies. Please go ahead and feel free. And of course, you can always request technical assistance from us at any time through our website or by emailing one of us. We really do appreciate your time. Thank you to Rebecca Bishop, to Dr. Sadiqa Kendi, and to Dawne Gardner for joining us today. We hope that you all got some excellent food for thought, some necessary next steps in your health equity and anti-racist approach to child safety. And we look forward to seeing you again in our next State Technical Assistance webinar in March. Thank you all, and have a great and safe afternoon and evening. Thank you, everyone.